This conference will now be recorded.
Just going to give Mary Helen and Peggy another minute or two to see if they are able to get on. And I believe Ashley's joining us as well.
Okay. While you're doing that, I'm going to run across the hall and get something to drink. Well, actually, never mind.
Just give Access Point another minute here before we get started. Looks like NFP has joined us. We've got Muskingum Valley and Neighborhood Family Practice on the line. Okay, it's a couple minutes after 3, so I think we'll go ahead and start, and hopefully the Access Point team can join us here. We are recording, so we can send it out to their team as well. Thank you guys for joining us today. We're going to be doing a presentation by Dr. Dana Valangian, who's on the line with us, and she's going to be talking about SBIRT, which is Screening, Brief Intervention, and Referral to Treatment. This is part of the series of trainings and topic discussions that we wanted to bring to you for this project, and we hope that you'll ask questions and chime in if you have anything you want to discuss further. I know I got a couple questions from Muskingum before the training last week when we were putting it together, so I did put some of those in at the end of the slide, and so maybe we can have some conversation among the 3 health centers, and then I'll bring us back together after Dr. Dana is done presenting to talk about next steps for this project. So I think with that, I will turn it over to you, Dr. Dana.
Okay, good afternoon, everybody. And yes, as Tiffany said, this can be relatively informal with the size of group that we are today. So feel free to chime in and ask a question if you have it as we go along. That would be just fine. So these slides that we're sharing with you today were adapted from several different sources, from a HRSA SBIRT presentation, a National Council for Behavioral Health presentation. And so we want to make reference to where a lot of the source material came from. So why is it important now more than ever to be doing SBIRTs? So we're really in the middle of two epidemics, the first being our pandemic of COVID. But prior to COVID starting, we were in an epidemic, especially here in the state of Ohio, with opiate use disorder and overdose deaths. And unfortunately, as we are seeing things evolve with the COVID pandemic, the social isolation and just increased anxiety and reduced access to treatment and harm reduction services is really increasing the epidemic that already existed for opiate use disorder. And I'm not sure about your counties, but I know here in Franklin County, we have had a significant increase in the number of overdoses happening in a week or a weekend, at least 4 or 5 times, I want to say, Tiffany, since COVID started. So yep. We are seeing that. And there is a national campaign going on right now that's pictured on this slide that you can find with the hashtag 2epidemics. My personal plug and opinion is that it's really 3 epidemics that we're in like a trifecta of, with the 3rd epidemic that COVID is also worsening is suicide. So we have kind of the confounding COVID epidemic causing death, the opiate use disorder epidemic, and then our suicide national epidemic. All 3 of those things are compounding and confounding each other. We've been over the last 4 years struggling with declining age and life expectancy as a country for the first time in a long time. And the intersection of these 2 and 3 and the 3rd epidemic will, I think, probably make that worse for us as a nation as well. So SUD and stress all go together, and we know from what happened after 9/11 that there was an intensity and an increase in binge drinking that persisted in our country for even 5 to 6 years after the acute stress of the event of 9/11. And we're definitely seeing some of those early statistics already here with COVID, that there is increased alcohol purchasing, which would then lead you to believe consuming going on as well. This just gives you a perspective looking at preventive service rankings and the importance of them. So the number 1 preventive service items based on the disease burden and cost effectiveness are immunizations and tobacco. But you see in the category of number 2, we have alcohol screening and brief intervention. So what are we going to talk about today? We're going to talk a little bit about the SBIRT model itself, how you would implement it, and some of the technology or behind the scenes things that are important to make that work well. And then there'll be slides with resources and references. So by the time we're done, we hope that you can speak well to the components of the SBIRT and what each of them stand for and what that component encompasses. We're going to present, I would say at a surface level, some of the billing and financial considerations for health centers with SBIRT. And then we want to understand the value of how and when to use the technology that can help support the SBIRT workflow. So what is SBIRT? So screening, brief intervention, and referral to treatment is great evidence-based practice, and it has been studied quite a lot at this point, and the data behind it is very solid. It is an evidence-based practice used to identify, reduce, and prevent problematic use, abuse, and dependence on alcohol and illicit drugs. So it starts with a screening, and out of that screening, patients are identified as either low risk, where there's no need possibly for further intervention. I would counter, that's not the way I look at it, and we'll talk about that in a little bit. I think that even our low risk patients, there's an opportunity for education and reinforcement. For moderate risk patients, that is our opportunity to do a brief intervention. And then for our moderate to high risk and severe risk patients, the opportunity to do some brief treatment and or a more formal referral to ongoing treatment. So how might this look in a health center setting? A lot of the health centers are having medical assistant or that first point of contact with a patient do the screening. And then it might be the primary care provider doing that brief intervention for those identified patients who are moderate to high risk or users. And then the health center itself may hand off those patients needing referrals and or treatment to their internal behavioral health teams. So if we talk a little bit further about the S part of the SBIRT or the screening, we want to assess a patient and client for substance use with a standardized screening tool. It's a professional level that can be done by anyone from MA to a case manager to whomever it makes the most sense in your workflow once they are trained. How long does the S part take? I would argue it takes less than a minute, but you can see that it ranges from brief to more detailed depending on the depth of the screening tool you choose to use. How can it be done? It can be done old school on pen and paper. That's actually how we started SBIRTs at Lower Lights. We had patients actually take them on pen and paper themselves as part of their check-in and or getting their vitals taken and being roomed process. It can be electronic, and we've already talked about it can be various levels of staff that can possibly be part of your workflow. What are some of the common screening instruments that can be used for the screen? This is a whole list. We have highlighted 3 things that actually kind of hang together. So the audit, which has an abbreviated version called the audit C, and that is for alcohol use screening, and then the DAST, which is for drug abuse screening. Those 2 items have probably some of the largest number of clinical studies and data behind them, plus they are pretty user-friendly. The audit C+2 is what we're actually going to talk about today, and it is the abbreviated audit for alcohol use plus 2 questions to screen quickly for drug abuse. So here is the audit C +2. So you could see the questions are: how often did you have a drink containing alcohol? How many drinks containing alcohol did you have on a typical day if you were drinking? How often did you have 5 or more drinks in one sitting or occasion? And then, so those are the audit C questions. And then the +2 questions for making this comprehensive for both alcohol and drugs with one screen are: how often have you used marijuana? And how often have you used an illegal drug or used a prescription medication for non-medical reasons? This slide goes over the way that you would score that and how it breaks down into a low risk or negative screen, and then a positive kind of medium risk, and then a high risk or severe score. This is actually a screenshot from my old EHR at Lower Lights, and we embedded our PHQ2 as 2 questions. This was before I knew about the audit C+2, but we used a couple of audit questions and then a couple of DAST questions. And so basically we were asking 2 questions, 2 questions, 2 questions. So in a total of 6 questions, we had done our depression, our alcohol, and our drug screen. And then it gave the opportunity, once it was calculated, it would populate the scores, and then gave an opportunity for staff providers to document whether they chose to defer the additional, more detailed screening, or whether they completed the more detailed screening and brief intervention on that visit. So the brief intervention part, or the BI, is usually by a healthcare professional, and the goal of it is to use the interaction between the patient and the provider to provide some feedback about the substance use or abuse for the patient. And so it's very brief counseling by their primary care provider. The goal is to do this screening at least annually for patients, and thus at least a brief intervention annually for patients with at-risk behaviors or positive screens. The focus is really on educating the patient so that you take the opportunity not to judge or be paternalistic about what you think the patient should be doing, but it really is an opportunity to hear from the patient about their use and to impart, hopefully, increased information that helps the patient have additional insight and awareness about the risk of their behavior. And so it really, at a core, is motivational interviewing. And I do think it's fair to say that this can be done and done really effectively in 2 to 5 minutes of the exam room time with the patient. So the key elements of the brief counseling are to begin the conversation and build rapport just like you would normally as part of the visit, provide feedback on the results of the screening, and provide advice or a clinical recommendation and support the patient in setting a goal or making a plan. The way to do that is with use of open-ended questions, connecting the substance use to the patient's health directly. So if, for example, the patient has diabetes and they're using or screened positive for alcohol with risk, to help them tie the fact that the alcohol may actually be part of the reason that their sugar is not well controlled. Elicit the patient's feedback and thoughts, provide a clinical recommendation, and then set a reasonable and obtainable patient-directed goal. So what might that look like? So tell me more about your use of alcohol, Mr. Smith. And then as Mr. Smith says, I'm concerned that drinking more than 4 a day or 14 a week might be affecting your blood pressure, is how you would tie back the drinking to a health-related issue for the patient once you've heard whatever the patient has to say about his use. And then exploring goal setting and plan. I think it's always great just to say to the patient, what do you think you want to do about this right now? Or what might be your next step? And then try to help the patient. Sometimes they'll come up with something that's huge, like, oh, well, I'm going to stop drinking, or I'm going to stop smoking. And then helping the patient just kind of hone that into a more realistically obtainable goal. I used to use motivational interviewing all the time in my chronic disease patients who were overweight. Well, actually, we had a whole list of things that we would show patients as they were roomed. And then the provider would come in and just follow up on, like, what in the picture today is something that you're interested in talking about. And they were all lifestyle related things. A lot of people would pick food or things that pertain to their weight. And then there was the opportunity to allow them to talk about how they were doing with that right now, to reinforce with them how it was affecting their health and how we thought it was important for them to work on a lifestyle modification or change. But then we had them set a patient-specific goal and we would allow them to do that and try to make it something they could actually achieve by the next visit, was how we tried to help them get more realistic with that goal. And then our last question would be, how confident are you that you'll be able to achieve this by the time I see you next, on a scale of 1 to 10, which is kind of the confidence that the patient had in the goal that they were setting for themselves. So for our patients who need more than just the screen and the brief intervention, for those who are at highest risk, the RT is about referral to treatment, and the goal here is to help get the patient into some form of treatment that is going to help them manage the alcohol and other drug-related symptoms that they are having. And so this can look a whole lot of ways and can be done, a lot of this in-house based on the services that you have created within your MAT programs or your behavioral health team. So you can refer to your own internal programming, or you can refer externally if you do not have the capacity. But this can be as simple as counseling, clinical counseling. It can be peer support, again, with a peer supporter that you employ, or you can refer out to AA or NA. Primary care support for self-management is one additional referral for treatment. So I could choose to continue to see the patient for the treatment on a regular basis and work with them. And then, of course, we have our MAT medications and or for opiate and or alcohol use disorder. So it's important, I think, to have in mind how you're going to do referrals for the patients that are high risk and that providers work with and are able to get to say yes to that referral to treatment. It's also important to continue to use the brief intervention to engage clients as you're transitioning them to treatment. And some of those things look like starting treatment on site if possible, assisting in making that initial appointment, having some case management support or transportation support or peer support. And then the health center, of course, wants to maintain a good communication and partnership with agencies external to yourself that you may be referring your patients with SUD to for outside treatment. So referral to treatment doesn't have to be defined as a success based on whether the patient says yes or no. If the patient says no, you still have completed the SBIRT in the sense that you've gone through the process and you've offered the referral to treatment. Those patients who are not ready for accepting treatment need to stay in kind of a mode where you're offering additional brief counseling or conversations each time that the provider, the primary care provider, interacts with the patient. Oftentimes it takes more than one conversation before patients are both have the insight and awareness, but also have the engagement level to be ready. When they do accept the referral, also don't judge yourself on dropout rates, because that tends to be pretty high. And again, you have to kind of keep this loop going with those patients to keep moving them towards eventual engagement and sticking in treatment. So what might SBIRT implementation look like for us at a health center? So I think that SBIRT and the PHQ-2 are they're like the way to catch and enhance and increase the effectiveness and the productivity of your behavioral health services, but it's also the real way to integrate behavioral health and primary care. So not only does it increase identification of patients with SUD, which is the main goal, but it helps your teams understand and integrate how they're working together on a level that I don't think happens until you really are doing SBIRTs universally and routinely. The early intervention obviously is we're striving to catch this early and to intervene early for patients so that we can reduce SUD and or their negative health outcomes from SUD. This can be a challenge to implement SBIRT just because primary care is busy. So sometimes your providers are like, I don't want one more thing that I have to think about or try to manage or try to respond to in an already complicated patient visit that isn't long enough. So sometimes it's that provider time and provider motivation. Sometimes it's not having a good referral plan. So why do we want to identify things that we then can't take care of? Sometimes it's just stigma and or lack of training and focus on the importance of SBIRTs and screening. So what would be the clinical goals that we want to achieve at the health center with SBIRTs? The fundamental goal is that we want to screen all adults at least once a year for alcohol and drugs as part of a population-based prevention and treatment effort. We also want to clinically explore additional symptoms related to alcohol or drug use from patients with positive screens, be able to offer that brief counseling that we talked about, manage alcohol or substance use disorders using shared decision-making and patient-driven goal setting, and patient-centered access to medications, counseling, or referral services. And then the step that sometimes we forget to focus on is creating a follow-up loop for this whole process so that we can continue to follow those patients who screen as high positives or at high risk. Whoops, sorry guys, I just flipped my screen. Let me get back. There we go. And then there are some administrative goals that from an administrative standpoint, we want to actively support improvements in care for patients with unhealthy alcohol or drug use. Administratively, we want to support and see quality improvement processes to help each of those 5 clinical changes occur in our practices that were on the prior slide. We want to help support administratively the training of the primary care workforce to feel confident and comfortable in managing alcohol and other substance use disorders and or knowing how to refer out if it's something that can't be managed. And then from an administrative standpoint, we also need to be cognizant of any billing issues, coding issues, and identification of financial resources for SBIRT and substance use care. So this is a slide that just summarizes the currently available CPT codes for SBIRT. I really think most practices, even the ones who are doing SBIRT, are not very regularly coding. And I think that that's because there isn't great separate reimbursement for doing SBIRTs, but I do think getting in the practice of having your providers and your EHR system able to use these codes, it's meaningful in that it helps a lot of the reporting. It also is meaningful because insurance companies and payers will start to see how frequently it's happening. And I know that this is an area that from a Medicaid perspective that we continue to try to advocate for, that it would happen more regularly and be more sustainable for health centers if there was a little bit of extra SBIRT reimbursement. This is a sample of an SBIRT policy, and I won't take the time to go through it, but I think it's just important to think from an administrative perspective as you're implementing this, what is important to actually put in the purpose of a policy, what do you want to accomplish, and who's responsible, and what are the important processes or workflows. From a technology standpoint, it's important to think about what you can do with your EHR in helping that screen be automated and embedded, helping the scoring of it be readily identifiable to the primary care providers. How are you going to track the patient? how's it going to trigger when the patient is due for their annual screen? How do we indicate if it's positive at a moderate level or a high level so that we know if brief intervention is what's needed or we need to do brief intervention and referral to treatment? Is there a clinical decision kind of support tool that can be part of this? What are the forms? If we can't use the EHR, what forms are we going to use? And then reporting is important, I think, to the follow-up of the process that you try to put in place, or if you're already doing SBIRTs and you want to work on process improvement, it's important to have a report that tells you, is it happening when it's supposed to be happening and by what percent? And then how are things going as far as following or continuing to track the patients who are at high risk and identified as having a need for treatment? I think that is the core of what we wanted to present content-wise today, Tiffany. So I don't know if I missed anything that you wanted us to talk about before we kind of have a discussion together.
No, I think that was great. And I think we wanted to kind of open some of these questions to the group because we talked to you about these on your individual calls, some of these questions, sort of what you're doing for screening now, what you're thinking about doing if you're formally following an SBIRT model or not. And so I think every health center, all three of you, has sort of dabbled in or started SBIRTs, but we just wanted to get you guys talking to each other about how it's going within your health center. And these are just some discussion questions that we wanted to prompt you with to get started.
Hi, this is Sue. So when we initiated SBIRT as part of the Ohio Perinatal Quality Collaborative for our maternal program. And that's really where it's at. I've been trying to get into the adult assessment and see, I know we get referrals from adults to the MAT program. And so I've been going to try to get in there and see if the same questions exist, but just not under a tab that's labeled as SBIRT. So Kylie, have you audited many charts and been able to see that?
Not at the moment.
Okay. Kylie's working from home in case you couldn't tell. But it's been very successful for us in the OB program. So we didn't do it just for the maternal addiction program. We started it in all OB practices, private practice, as well as in our program here at MBHC. And that's how we get many of our referrals from the private practices.
Great. And are you, Sue, is Muscam currently screening any adolescents or anyone under 18, or were you thinking about that? I know Kylie sent over a question just based on our objectives in discussing universal SBIRT screening, which I think was in our training components that we had initially sent to you. And I was just wondering if you guys are.
Well, we have talked about that here. Our problem is that at the current time, we don't really have a provider who is willing to prescribe or deal with that adolescent addiction population. And so we've been hesitant to, where do we go? Once we identify the person, right now, the only place that we can refer to is Nationwide Children's Hospital. There are not many adolescent programs in our area. Do any of you have an adolescent program?
You can hit unmute. Oh, there, looks like.
We don't have one at Neighborhood Family Practice for adolescents.
Are you doing any SBIRT or screening with adolescents, like universally, or?
Right, I will have to ask my supervisor about that. I know we do SBIRT with adults, and that's a great question about adolescents, so I will check into that.
So is your SBIRT embedded in your EHR?
You know what, I just was looking in the EHR to see if I could find it in our flow sheets, and I didn't see it, so I think they're doing a paper version, and
Okay.
that's going from there.
Yeah, like I said,
And
we started on paper, and it took us a little bit to be able to work with the EHR vendor and or support to get it customized.
Yeah. Yeah, I know that the workflow here is that the MAs do it before the provider goes into the room.
And are you doing it once a year or?
Yeah, once a year. Mm-hmm.
Just out of curiosity, do you do your PHQ2 once a year?
Yes,
Or is?
Yes, PHQ also. Mm-hmm. And we do those for adolescents also. So I will find out about the SBIRT piece.
do either of you, I think Access Point maybe dropped off. I'm not sure if they're still on the line, but does NFP or Muskingum Valley have their SBIRTs audited as part of your quality team's work? Do you know how many you're doing, or if you're actually getting them done annually on your patients?
No, we don't currently audit. When we first started with the Ohio Perinatal Quality Collaborative, we did, but today we do not. And listen, I did just go into an adult chart, and I do find that there is an alcohol screen that does ask pretty much all of the same questions. So they are definitely screening.
Are they screening just alcohol or?
No, they do alcohol, substance. They also do tobacco. So they are screening. We might have to tweak it just a little bit, but the basics are there.
Great. Are you guys having, do you have a sense as to whether your SBIRT process is actually feeding any counseling or MAT services? Like, is the linkage, I guess, happening?
So at MVHC, on the adult side, or on the maternal side of things, it absolutely is. And
yeah, the adults.
Like I said,
yeah, I guess I was asking.
On the adult side, all I can tell you, I wasn't even sure these questions existed, but that kind of explains why our behavioral health providers and counselors are actually being called over to the adult pods if they have a patient who has answered these questions, and they ask the patient, are you interested? Then oftentimes they will walk right over and say, hey, is there a counselor who can come and see this patient? I have a patient who's interested in getting some help. The beauty of the FQHC, as far as I'm concerned, is the fact that our behavioral health and mental health services are embedded right in our facility, and it's just that easy to get a consult.
Great.
So the way our counselors in the MAT program and in our OB program work is that they really are integrated. They're downstairs working right beside the team. And so, like I said, it is not unusual at all if we're doing a new OB admission and there's either suspicion or they've asked the SBIRT questions and they identify a problem, they will immediately have one of the counselors or my addiction navigator come in and talk to the patient so that we can do that intervention. And like I said, it's also not unusual that if the teams are down there working, because the adult pods are very close to the OB and the maternal program, that they'll just walk across the hall and say, hey, can somebody, a lot of times they'll call me out of my office and say, hey, everybody's tied up. Would you mind coming down and talking to a patient? I think what we have to do is just formalize that referral process so that we can track it.
Sure. And I know both of you, I'm just looking back from our initial call, and Beth, it was Peggy that told me that she thought that providers were getting onboarded to SBIRT and what to do and how to really review the scoring when they started their training. And Sue, I'm not sure if you do this at Muskingum either, but do you feel like when you have a new provider come on board, they're comfortable with the concept of SBIRT, or do you think there's any assistance we can provide?
At MBHC, that is definitely a need here. You know, I have not been involved in any education of new providers on SBIRT. And like I said, the initial education on SBIRT at this facility was all OB related. And yes, as we've added addiction providers, they get the education because they work with it every day. So I would say that is something Kylie and I kind of have, it's something we're going to have to tackle.
Sure.
Well, feel free to use this content. We did record it and we'll be sending it to you. So if you want to share with your providers, we can send the recording, and we can also snip it too to just be the content.
That'd be great.
Dana, you're still sharing your screen with us.
Did anyone watch the MAT series that was put out by the state, the one of like the 23 curricula? Do you guys know what I'm talking about? I think it was recommended that we watch like 4.
Yeah. Yep,
okay, so within that, right. So right in there, I think there is also a training on SBIRT in MAT.
Yes.
So I haven't watched that one. I'm wondering if that is also a good tool maybe for recommending people to learn more about it.
Yes, I think it's a great resource. I think it definitely has more depth for providers.
Okay.
So if you're looking for something for your providers to train with or get a better understanding, that would be a good resource. And then SAMHSA, we didn't click to the resource slides, but SAMHSA also has, let me see if I can, sorry. About
okay.
my calendar a minute ago. I'm having trouble for whatever reason. There we go.
There you go.
So the SAMHSA SBIRT link here also has good provider training.
Okay, thank you.
And in addition to the Ohio opioid curriculum, there's another free e-based academy at that link there for SBIRT as well. I believe they're similar, but I haven't watched the one that's linked here with the one CEU. Any other questions or topics that you guys wanted to discuss around SBIRT, or how your referral process is going into your MAT program?
I don't think so at this point. I am working on, Dr. Dana, trying to get my providers together to have you talk to them about treatment for methamphetamines and cocaine.
Okay.
So I'm waiting on one more provider to give me a date that will work, and then I think I'll be ready to set that up with you.
Okay, sounds good.
Well, in terms of next steps, if we don't have any more SBIRT related topics to discuss, our next meeting is set for June 18th. We don't know yet if we're going to be doing some more training-based discussion, or if we will just facilitate a discussion amongst the three of you. We'd love to hear more about your providers doing the Ohio opioid curricula, so we might want to talk about that. And then we still have the hepatitis C training and discussion on deck before the end of this project as well. We are trying to align that training with a cohort of 2 health centers that we are hoping to get a small grant to work with them as well. And we thought about bringing the 2 groups together since it would only be 5 health centers in total. So I will get back to you guys with the specific content for the 18th, but that's the next time we will come back together. And then for your data collection, the 2 measures and the subsequent, or the sub-measures of measures 1 and 2, I guess, of your population that you're treating with in your MAP program. Sorry, I'm getting tongue-tied. The reporting period is April 1st to June 30th, and we normally give you guys a week or 2, given that it falls within the 4th of July holiday. If you could submit those by July 13th to give you a little bit of time to get the data collected after the end of the month, that would be great. And I'll be sending out a reminder too at our next meeting for you on that. So I think that's all I had to share with you guys. And thank you, Dr. Dana, for sharing and presenting on SBIRT. We appreciate it.
Absolutely. Thank you guys.
Thanks so much.
Thank you.
Thanks. Have a good day.
Okay.
Talk to you guys
Thanks, you
later.
too. Bye-bye.
Bye.
Bye.